So I'm, as Sarah said, an ENT surgeon and otologist at St Vincent's Hospital. I joined the department when John was an active member of this department, and we pride ourselves in our work, and we have a lot of experience in managing ear problems and also with implants. And I'm going to take you through today a little bit of a through the, implantable hearing devices, which is probably the most exciting area of ear surgery that we have. A little bit about what's happened in the past, what's happening currently, and where we're going in the future, and give you a bit of a tour through this area. So as far as hearing loss, I'm sure many of you have heard that 1 in 6 Australians have a hearing loss, and the number is increasing as our population is ageing. Over 50% of people between the age of 60 and 70 have some sort of hearing loss, and that figure is over 70% once you reach the age of 70. And we have a large number of people, an increasing number of people, who are severe to profoundly deaf. And this cost to the community is quite significant, and it's something that we should be managing better. We're certainly not treating everybody with significant hearing loss in the country. Before I talk a little bit about implants, I just want to give you a few basics about the ear, and a lot of you may recognise a picture of the ear and the various structures, and it looks a little bit complex, so I've just broken it up into some very basic parts. So we've got the ear canal, which is not straight, and nobody should put any cotton buds down their ears, for those who do. We've got the eardrum, which is a very thin membrane, and the eardrum and the little bones of hearing are an amplifier mechanism. So the eardrum and the bones of hearing amplify sound waves from the outside world through to our inner ear. Oops, gone too far. So the inner ear is called the cochlea, and the cochlea is the part of the ear that turns sound waves into nerve impulses. It's a very complex mechanism. It's a very amazing mechanism how it does, and we're only just starting to understand the complexity of that system. And for those of you who will listen later to Professor David Ryugo, he'll talk to you a little bit about the mechanism of hearing transduction. David's doing some fantastic work in researching how we hear and how that information is processed in our brain. So as a surgeon, we look at the way we can try and help hearing through surgery, and we have 2 types of hearing loss that we deal with. We have what we call a conductive loss. So this is the sort of loss that the Honourable Mr. Howard had with otosclerosis, and this can have a range of causes. So this may be due to a problem in your ear canal. You may be born without an ear canal. You may have some sort of injury to your ear canal that blocks the sound getting through. We may have a problem with our eardrum. The classic is having a hole in your eardrum. If your eardrum doesn't work well, the sound doesn't get through. We may have a problem with the bones of hearing, and otosclerosis is a condition affecting the stirrup bone or the stapes bone, which is the smallest bone in the body. And we have what we call conventional operations to fix these problems, and we also have implants. As far as the inner ear, there are 2 essential ways to manage that. From a non-surgical perspective, it's hearing aids, and from a surgical perspective, it's implants. So what is our ultimate goal in hearing devices? Now, we don't want to turn people into the Terminator or anything like that. The ultimate goal is to provide an implant that improves somebody's function, but has minimal impact on the person, is not visible, and is something that they can work with on a day-to-day basis. So I've just broken it up into the 2 types of loss and the different implants. So the first type of implants I'm going to talk about are those for conductive losses. So these are essentially problems with the ear canal, the eardrum, or the middle ear, the bones of hearing. And these implants generally rely on the fact that your inner ear, the cochlea, works reasonably well. And they rely, bone conduction is where if you put a sound directly on the bone of your skull, it gets transmitted through to your inner ear with bypassing the ear canal and the middle ear mechanism. Solid objects conduct sound very, very well. Air is quite a poor sound conducting medium comparatively. So if you put the sound directly on the skull, you can hear the sound very clearly if your inner ear function's good. And the classic device or implant for this sort of thing is what's called a bone-anchored hearing aid, or BAHA. And the bone-anchored hearing aid essentially involves placing a titanium screw in the skull, and then we connect a hearing aid directly to that titanium screw. Now, many of you may have heard of dental implants, people having a titanium screw put in where a tooth used to be and attaching a tooth to it. Well, the same sort of technology, except rather than attaching a tooth to it, we attach a hearing aid to it. Bone-anchored hearing aids have been around for a long time. They were actually developed in Sweden by Professor Brannemark, and 1977 was when they first started. We really didn't see much of them in Australia until the turn of the millennium, but they were first fitted. And these implants rely on the fact that if you actually get pure titanium, so 99.99% titanium, it actually, unlike many other metals, it bonds with the bone. The cells in the bone actually bond with this metal, and that makes it very secure and makes it last a long time. So bone-anchored hearing aids are used currently in two main circumstances. So these are when people are unable to wear a conventional hearing aid. So if somebody comes along and due to either infection or a problem with their ear canal or some sort of issue where they just can't wear a normal hearing aid, we would look at using a bone-anchored hearing aid. And the other reason we might use it is in what we call single-sided deafness. So if you've got pretty good hearing on one side or normal hearing on one side and you're totally deaf on the other side, if you actually put the implant on your totally deaf side, it sends the sound signal across to your good side, and so you can pick up sound on that side. So what we call single-sided deafness. And they're the two main reasons we'd use a bone-anchored hearing aid. These devices have developed through the years, as I showed you the history. The first one was put in 1977, and we've seen a lot of developments over the last 10 years. The little titanium screws, which are just 4mm by 8mm, have been developed, and this is the current implant that we're now putting in. The surgery has developed a lot. When I started doing this in 2001, it was quite a long procedure. Now it's a simple day surgery procedure. You're in and out. It takes perhaps half an hour. It can even be done under local anaesthetic. The other thing that really has made the difference is the hearing aid technology has improved a lot. When they first started, they were fairly basic devices. There were some issues with them, and the current devices are much, much better. They're now digital devices, and they've got a number of adapters. So both the implant and the hearing aid that attaches to the implant has developed a long way. Where are we going with bone-anchored hearing aids? Well, the latest thing, which we're actually just starting to do here in this hospital as one of the first places around the world doing that, is these magnetic bone-anchored hearing aids. One of the issues with a bone-anchored hearing aid is some people don't like the cosmetic appearance of having a little titanium screw coming through the skin. So we're now looking at placing these implants where we put the titanium screw in, we place a little magnet under the skin, and then the hearing aid is held by another magnet over the skin. So when you take it off, there's nothing to see. So that's very exciting for us, and this is something that we're literally just starting to do. And you'll hear more about it as this system is rolled out around the world. So that's quite an exciting thing. It won't be for everybody. To be fair, it's not going to be as good a hearing as the conventional bone-anchored hearing aid because you'll lose a little bit of sound quality through the skin. But for some people, they'll trade that off for the cosmetic appearance. And where are we going in the future with bone-anchored hearing aids? Well, we've got the conventional one which comes through the skin. We're just starting to do this one, and we're probably going to move towards devices that have a little chip inside them under the skin and further transmit sound. So that's exciting for us, and we'll see that develop over the coming years. There are other bone conducting systems available, and the other one that is around is something called a bone bridge. And this is a little bit more complex device. It's got a big magnet inside that vibrates and transmits sound through the bone. You have to implant this device under the skin, and there's a little hearing aid that sits on the outside. So this is what we call a semi-implantable hearing aid, a bit like the bone anchored hearing aid. Part of it sits under the skin and part of it sits on the outside. It has a good sound processor. It has some limitations. For example, if you've had mastoid surgery or major ear surgery, you may not be able to use this device. And unfortunately, because it's quite an expensive device, it's not being covered by health funds in Australia, and we'll have to wait and see whether or not that happens. But it is a new device, it is around on the market. There's just not as much experience with this device as there is with bone anchored hearing aids. There are other implants for inner hearing loss. So we've talked about conductive losses, and really those two for conductive losses are the bone bridge and the bone anchored hearing aid. The bone anchored hearing aid we have by far and away the most experience with. But there are implants, or what we call implantable hearing aids, available for inner ear or cochlear hearing loss. And this is something that has been worked on for over 15 years. It's a bit of the holy grail of implants. And there are lots of different types. Some of them are fully implantable and some of them are semi-implantable. Fully implantable means you put the entire device under the skin, nothing to see. And semi-implantable means there's part of it, you put part of the implant under the skin and there's still a little external component that you have to wear. But the aim, of course, for every company who develops these is the fully implantable hearing aid. The sound bridge is probably the best known of these, and the sound bridge has been around since the 1990s. This is a semi-implantable device, again, part that implants under the skin. It's got this very tiny little magnet in there that we attach to one of the little bones of hearing, and there's an external device. Again, unfortunately, it's a somewhat expensive device, so it's not covered by health funds within Australia, so it's not widely used, but it has been used overseas. There have been some cases of implantation in Australia, and it's used for moderate to severe nerve loss, or in situations where perhaps all the little bones of hearing might be missing. So it's something that we have in our armamentarium, we just don't widely use them. There are other devices that are being researched and we're moving forward in. There's things such as the DAX. So we have a little tiny stapes prosthesis. This is the sort of prosthesis that is used in stapedectomy and otosclerosis, and that attaches a little mechanical driver to it. There is this device called the Carina, which is available in the US, which is a little piezoelectric driver that you actually drill in and attach to one of the bones of hearing. This is a fully implantable device, so very exciting as far as the fact that patients will not have anything to see on the outside. The limitations in these devices is their battery life. The battery life, I think, for the Carina, and the next one I'll show you, the Esteem, is about 4 or 5 years. So then there's questions of how you change the battery and how do you charge these things. The other one that's available in the US is called the Esteem. So we don't have access to these devices yet. We're watching their development overseas, and perhaps we're going to see in the future these devices becoming available. But they are exciting because they're fully implantable. I think there's still some work to come on these devices, but we're certainly seeing them. There's another device called the Maxim, which involves putting a little prosthesis in the middle ear, but you have to wear a hearing aid device in the ear canal. So what the key features with all of these implantable hearing aids that we need to think about as surgeons and audiologists dealing with them is how reliable are they? For example, battery life, how long are they going to last for? How difficult is the procedure to implant them? Now, a bone anchored hearing aid, as I said, is a very simple device to implant nowadays, and that's why it's very widely used. Some of those implantable hearing aids that I show you are quite technically difficult to implant. So that's going to be a bit of an issue. What's the risk to the patient? And of course the cost. Is it going to be something that only young people can get? Is it something that only old people can get? Can we afford as a community to pay for all of these devices? So that's a little bit about implantable hearing aids. Oops. Now, implants for inner ear hearing loss, as I said at the start, really we've got, for inner ear or cochlear hearing loss, we've really got hearing aids and implants, and there's not much in between. But cochlear implants, which you've all heard of these days, very exciting devices, and essentially involves putting an electrode in the cochlea or the inner ear to directly stimulate it. It's actually been around, the concept of directly stimulating the nerves has been around for a very long time. Volta, who invented the battery, placed metal probes in his ears back in the 1790s. And not only did he give himself a dreadful shock, but he actually also heard a noise, which he described as similar to the sound of boiling soup. Then in the 1800s, de Bologna reported a buzzing and ringing sensation when he tried AC currents rather than DC currents. And then back in the 50s, in France, in fact, a surgeon placed an electrode on the stump of a hearing nerve. Actually put the electrode directly on the nerve on somebody who had had severe problems and major ear surgery, and the patient described a perception of sound. Then in 1960, William House, who's from an otologist perspective, one of the fathers of ear surgery in LA, developed the single channel cochlear implant. So this was a single electrode placed in the cochlea, and Dr. John Tonkin here was the first surgeon in the country to place a cochlear implant. We've all heard about Professor Clark, who's very famous and brilliant in his work, but John actually put in the first William House 3M implant in the country. And this is where Graham Clark started his work in the 1960s, and there was a lot of competition actually in the 60s between various units around the world. There was the US, there was Europe, and there was here in Australia, and Graham, with his work and his team, was able to be the first successful multi-channel cochlear implant. So the difference being that William House put in a single channel which gave very limited information, but Graham was able to put in these multi-channel implants which gave a lot more information, and that's where we've moved on for. So, and a lot of you would have heard his story. It basically, multi-channel implants work by the fact that the inner ear, so it's like a snail shell, has different frequencies in different parts. So the fatter part of the snail shell, the sort of what we call the basal turn, is high frequency, and the apex, the very apex of the snail shell, is low frequency. So if you can put in lots of different electrodes around this area, you can stimulate different frequencies. And that's the brilliance of cochlear implants, that you can stimulate different frequencies, therefore you can code different speech information and give people a perception of sound. And hopefully we'll see. So this is just a little video courtesy of Cochlear. Just shows the little electrode that gets inserted into the inner ear, and there's all these different nerve endings representing different frequencies within the inner ear, and you can stimulate different frequencies and different nerve endings, and that's how we transmit sound in cochlear implants. So as far as cochlear implants, since they were commercially available, we've seen a lot of development from the very basic models through to the current model, and there's been a lot of work in this area, and the processes have gone, just like from hearing aids, what we call body-worn devices, they've gone into essentially little devices that sit behind the ear. So there's been a big improvement in these devices, a lot of work, particularly pioneered by Cochlear, who's that Australian company that Graham Clark was associated with and developed. And in fact, cochlear implants in Australia, the Cochlear device is made up in Lane Cove. So it's a local device. So the external device has gone from very basic to very modern. We've got remote controls. The internal device, the part as surgeons we place in the inner ear, has gone from, again, a very basic device to a very modern device. It's amazing the fact that in that little tiny electrode, which is less than 1 millimetre wide, are 22 separate wires, separately insulated. Each wire is thinner than a human hair. And the fact that they can manufacture that's quite amazing. The electrode that we actually place in the inner ear, there's been a lot of advances in the design, and the whole point of that is to not traumatise the inner ear as we place it, because now, and I'll mention, we're starting to implant devices in people who still have a little bit of residual hearing, and we want to place the implant, preserve that residual hearing, but assist the parts of their hearing that they're missing. So where are we now with cochlear implants? Well, essentially any age group. So we implant the very young, a child born with with profound hearing loss. These days in Australia, the expectation is they will get a cochlear implant in the first year of their life. The expectation is they'll probably get bilateral, so if they're deaf in both ears, they'll get 2 cochlear implants. And that's our expectation, and our expectation is these children will go to normal schools, lead a normal life. Elderly people can have implants. There is no limitation on age. The only limitations we have as far as age is your general health, your ability to have an operation, and your mental capacity. As long as you've got enough mental capacity to cope with a procedure and learning how to use an implant, there is no restriction on age. I think our oldest implantee in the country is around 93 or something, so there's no restriction on age. Generally, we will implant people with quite a severe hearing loss, and our rule is essentially if somebody comes along and says, or their audiologist has told them, I can't turn your hearing aid up anymore, and these people are not able to cope, they're getting 50% or less of the information, even with their hearing aids at maximum, they're a cochlear implant candidate. So we need, we're expanding the number of people that we can use cochlear implants for, and the growing market, I suppose, if you want to describe it as that, in cochlear implants is in the ageing population. As we all get older, there's more and more hearing loss, people are living longer, and there's more and more people who will benefit from a cochlear implant. People do need to be well motivated with these devices. They're not a simple hearing aid, they do take a lot of work, and you have to have appropriate expectations. Unfortunately, there is no device and no hearing aid that will give you the hearing of a 21-year-old. As I said, young children, the elderly, we can implant any age group. So as I said, that's a little bit of where we are now, and there are other things that we're starting to do with cochlear implants. So one of the things that we're undertaking is people who are just progressively becoming deafer and deafer, and they might reach the point where they can function with a hearing aid in one ear, but their other ear has reached the point where it is beyond hearing aids. Now, to us, these people are now candidates for cochlear implants. And we used to worry that the brain didn't like the 2 different types of information, but in fact that's not true, and people can adapt very well. So we can look at leaving a hearing aid in one ear, putting a cochlear implant in the other ear, and if that person, through age, develops further loss in their hearing aid ear, then they could end up having a cochlear implant in the other ear. So it provides a good combination of information. We're certainly looking at bilateral cochlear implants. There's big advantages of being able to hear on both sides of your head. If you only have one ear, you have what we call mono sort of hearing, which means you lack directionality. It also means that you lack, or you have a lot of difficulty coping with background noise and hearing the sort of one voice amongst the many. And if you can improve hearing in both ears, and this is not just for cochlear implants, but for any hearing device, you can generally improve people's function. The only question with cochlear bilateral implants, I suppose, is really an economic one, a cost to the community. We also have these implants. We've got patients who have a unusual sort of hearing loss, who have a very, very severe hearing loss in the very high frequencies, but actually not bad hearing in the low frequencies. And we know that if we put a very small, fine electrode in the cochlea, just in the basal turn of the cochlea, the base of the cochlea, we can assist their high frequencies, but we can try and preserve their low frequencies. So these are called hybrid implants, so they're part hearing aid, part cochlear implant. And that's the sort of hearing loss. I know Vanessa or Patrice was talking about interpreting hearing aids, but this is somebody who's got quite good low tone hearing perception, but they've got very little high tone perception or mid to high tone perception. A person like this will struggle with a hearing aid because you can't amplify that sort of hearing loss, it's so bad. this is a very exciting area that again we're moving into, and this is for single-sided deafness. Now I talked to you before about bone-anchored hearing aids, and the bone-anchored hearing aid, if you're deaf on one side and you've got good hearing on the other, you tend to ignore that deaf side of your world. So if Mr. King, who's a neurosurgical colleague of mine from Manchester, is deaf in his left ear, he's going to ignore that side of the world. He just, people talking to him on that side, he's not going to hear. And we've got a couple of devices currently to help that. You can wear what we call a cross aid, which is a hearing aid with a receiver on one side and conventional aid on the other. But if you're young and you've got normal hearing in your other side, you don't want to wear a conventional aid on your good side. You can wear a bone-anchored hearing aid, so you could put a bone-anchored hearing aid on his left-hand side, and that'll give him sound perception on that left-hand side, so he's not ignoring that side of the world. But what it will not give him is directionality or that stereo hearing. And so we're looking at, and it's been trialled around the world, and there's been quite a few hundred patients around the world, and here in Australia, and some here in Australia, who've had cochlear implants when they've got almost normal or normal hearing on one side, and we put a cochlear implant on their totally deaf side. And what they're getting back is stereo hearing. So they're getting better directionality and better function. And this is a very exciting area for us. It's not going to be for everybody because it's quite a big procedure, but it is an exciting area, and this is where I think we're going to go in the future. So then there's the sort of next question, what if a cochlear implant doesn't work? So say for whatever medical reason you've had a cochlear implant or you don't have one that works. There are things called brain stem implants. This is something here we do at St Vincent's. They're very few and far between, and they're a very specialised device. But essentially this looks like a cochlear implant, but we've got little electrodes that we actually place on the base of the brain and stimulate the hearing pathway in the base of the brain. This is not a widely done procedure, but there are devices out there for people who even fail cochlear implants. And they're even looking at other devices being researched, what we call midbrain implants, which is this nasty looking spiky electrode which we place higher up in the brain, again in the hearing pathway. So there are devices, and there's a lot of research going on in hearing devices and implants. So the future of cochlear implants, really I think there's just going to be a greater number of people who will benefit from implants. So those who are, when I started doing implants, you had to be pretty profoundly deaf in both ears before we'd even talk to you about the possibility of an implant. As I said, now you can come in if you've got beyond hearing aid in one ear, using a hearing aid in the other, you'd definitely be an implant candidate. And we're even looking at people who have suddenly lost hearing in one ear who have good hearing in the other ear. So bilateral cochlear implants and cochlear implants for single-sided deafness is, I think, something that we're going to see will become the norm. And this is the sort of holy grail of cochlear implants, which is the totally implantable implant, which is actually being developed in Melbourne. It's very much a trial basis, so it looks like a cochlear implant, but you don't have the external hardware. So again, it's driven by a battery inside. I think they've got the battery life to about 10 years. So that's something that's quite exciting, but again, it looks like a cochlear implant, and that's again where we're going in the future for implants. So hopefully that's given you a little tour through where we are in implantable hearing devices. I certainly think they're increasingly available. It's a very exciting area. We do have quite a range of devices depending on the type of loss a person has, and there's been a lot of advances in technology. It's not applicable to everybody. Most people in the community will still benefit from a hearing aid first, but it is an exciting area and we will see more advances in it. Thank you.